So welcome everybody to the first Umeå Arctic lunch seminar for this fall. You're very welcome. And I'm very happy to see that so many of you are joining us today. So today we're going to listen to Professor Bertil Forsberg talking about health effects of heat waves in the northern areas. If you want to ask him any questions, the easiest way is to write in the chat or raise your hand, and I will try to give out the word after the presentation is over. Is that does that sound good to you, Bertil?
I think that's good, and if you follow the chat,
yeah, I will.
Best, I think.
Fantastic, and I also want to point out that the whole seminar is recorded and will be uploaded to our webpage afterwards if anyone wants to view this in retrospect. So I see here someone asking me if they should hear any sound right now, and the answer is that they should.
Maybe we could also maybe we could decide that we stop recording when questions maybe are asked after the presentation, so that we don't record questions. Yeah.
All right, absolutely. We'll do it like that. Once again, welcome, and I give the word over to Bertil then. Thank you.
Well, thank you very much for asking me. This was planned to be held during spring, but you know, a lot of things happened this year, so we became a bit delayed. Perhaps I should tell you a bit about myself. My main research field is air pollution and health effects of air pollutants, and also air pollution research was what brought me into the field of research on extreme weather and climate change. It was, I think, almost 20 years ago now that I was preparing a paper on health effects of ground level ozone in 28 European cities, and people arranging a meeting on climate change and health effects. They somehow knew about this project and paper, so they asked me to come to a meeting in some beautiful small city in Italy to talk about ozone effects, because ground level ozone is one of the problems that will increase with higher temperatures, because the formation of ozone is temperature dependent, everything else kept constant. So it was air pollution research that brought me into this field, but and I'm still mainly doing research on air pollutants. But today we will talk about extreme temperatures, and we will stick to the warm side. So this is what I'm going to talk about. What is a heat wave? Are heat waves a new health problem? How large are the health effects during heat waves? Is heat worse or better in the north? And can we reduce the health impacts from heat waves? And we said that you could ask questions at the end, but if there's something really impossible to understand, perhaps someone could stop me and ask for an explanation. So what is a heat wave? Well, we could say that there is no general definition. I mean, no golden definition of a heat wave. There are many different definitions, and SMHI, the Swedish Met Office, has its own. Since how long, I don't know, and how it was decided from the beginning, I don't know. I think it's 5 days with at least 25 degrees, 5 days in a row with at least 25 degrees. I don't think it's based on the consequences, but on something else. And it's not used in studies of health effects. And it's also a bit confusing because we have now a heat warning system in Sweden, which not at all uses that definition of a heat wave. Usually the definition, the national or regional definition, is based on that it's a heat that seldom occurs at the specific location. So it could be defined as the heat which is exceeded only 2% of the summer days in the city or the region we talk about. Usually a heat wave is defined as a period over at least 2 days, sometimes or often maybe more than 2 days, but there are exceptions. For example, in UK, a heat wave could be a one-day episode. In some warning systems, heat wave is defined the other way. It's defined using the typical effect on mortality. So, for example, the authorities decide that a heat wave, that is when we have 10% or 20% higher mortality, typically, than what we would have with normal temperatures. So it's defined based on the consequences. Different climate zones or different climate within the country could lead to region-specific definitions of heat. So this is, for example, definitions from UK. You see in London, the temperature has to reach 32 degrees Celsius in order to be defined as a heat wave day. But in the colder northeast, it's 28 degrees, which is the threshold or the definition of when you have a heat wave. And if we go to a country like Italy, which has the northern parts in the Alps and the hot Sicily, they have, I think, 9 degrees difference between the thresholds in their warning system when they warn for heat wave in the north and in the south, respectively. So definitions could be really region specific. And this is, of course, explained by the fact that the threshold for the increase in mortality, the effect on mortality, varies with climate. This has been observed in many studies for quite a long time. And these graphs come from an EU-funded project where we, from Umeå University, contributed with Stockholm data. There was a group of Mediterranean cities and there was a group of North European and continental cities. And if we look at the maximum daily apparent temperature where mortality starts to increase, it differed in this study about 6 degrees between the North continental cities and the Mediterranean cities. And the apparent temperature is a way to calculate temperature which takes which is taking humidity into account. But heat waves and extreme heat is not a new problem. We could go back to really historic notes and also papers or letters to the editor, like here from 1757, about an extraordinary hot episode in where was it? Plymouth or London. So the effects of heat has been described for many hundred years, and even I think even in Hippocrates had nice discussions about the health effects of heat. Although heat was discussed as a health problem long ago, the type of health effects associated with heat waves differs. If we look at medical notes a couple of 100 years old, the main health effects during heat waves is an increase in infectious diseases, diarrheal disease and so on, because microbes in water and food made much worse problems during hot periods than periods with normal weather. So for example, the drinking water was a problem during hot periods. Today we focus on the more direct effects of heat on vulnerable people. So heat and heat waves have always existed, but climate change has worsened the heat episodes we suffer. And in this paper from 2018, it said, for example, that over 30 years, the hottest day of the year has become, on average, between 1 and 1.5 degrees hotter in Europe. In this mapped illustration, the redder it is, the larger is the increase in temperature the hottest day of the year. So this is something that we are observing, the worsening of heat waves. And heat waves, they become more and more frequent. In this paper from 2014, the authors state that heat waves that at the end of 1990s were expected 2 times per 100 years, with the climate that we knew, they can now, with the climate that we seem to have, be expected every 50 years. So this is, of course, also why we often now hear about extreme heat waves and are told that this should happen only once in 150 years or so, but it seems to happen quite often. One of the most extreme heat waves, not so far from Sweden in recent year, was the one that hit Russia in 2010, where only in the Moscow region around 12,000 excess deaths were estimated. 12,000 deaths in a bit more than 1 month. What happened here was that the weather was very hot and dry, temperatures were extreme, and the dry weather also made that this region got a lot of wildfires. And if we study this graph from a paper describing the effect on mortality, you have the black curve, or 2 black, one is a straight line, which marks that normally daily mortality in this region should be a little less than 300 deaths per day. And then you have the curve raising from mid-July up to around 900 deaths per day, a few days. So mortality was 3 times the expected during some days here. The red curves shows the daily mean temperature. You see the typical or expected, the smooth line, and then you see the observed temperatures that were quite many days around 30 degrees. But you also have a blue curve, which where the straight line lies somewhere, if we look at the right axis, maybe it's 12-15 micrograms per cubic meter of particles. That's the normal concentration in this region. Particles here are measured as PM10. It's suspended particles less than 10 micrometers in diameter, in aerodynamic diameter. And then you see the blue curve with the spikes, that some days concentrations were very high, up to 600 or a bit above 600 micrograms per cubic meter. This is when media talks about extreme smog in Beijing, for example, we talk about that kind of concentrations that Moscow experienced during these surrounding wildfires. And it has been estimated that the around 12,000 deaths in the Moscow region during this heat wave were partly due to heat, of course, but maybe up to around 3,000 of the deaths in the region were added because of the high particle concentrations at the same time as the weather was very hot. And this is not unusual that we have hot weather and wildfires and high particle concentrations at the same time. So in a way, you could see the wildfires as part of the hot weather and the heat wave. And this is also what we are seeing now at the American West Coast with the fires and the high particle concentrations, together with the very warm, very hot weather. So this is one of the most extreme heat waves close to Sweden. And if the high pressure this time had moved a bit more to the west, maybe Finland and Sweden would have been hit very badly by this that time. During 2018, you may remember that we had very hot weather in Sweden. In many parts of Scandinavia, we had during 2018 the hottest, the 3-day average 4 or 5 degrees hotter than ever recorded before. Compared here, it's compared to the period we usually use for meteorological comparisons with climate change. It's 1981 to 2010, and you see that the hottest 3-day average during 2018 compared to that period in many places there are 4 or 5 degrees higher, or even more. It was really extreme. I've seen different calculations how unexpected or how seldom we could expect to have this kind of heat in Northern Europe with the climate we knew, but with the climate we seem to have, maybe it will occur more frequently. The summer heat was bad 2018. We understood already during the heat wave. I mentioned before we started an interview or a discussion I had with one of the ministers that we calculated based from studies we have conducted already earlier in Sweden with maybe not so extreme heat waves, but we could still use the relative increases we had seen and apply them on the temperature data we had from 2018. And we soon realized that this is going to mean many hundreds of excess deaths compared to a normal temperature. And when we summarized afterwards, we saw that the observed number of deaths during 5 summer weeks were about 750 more than normal, and using different models for typical summer heat, we estimated at least about 600 excess deaths. So it was a difficult situation. And we also, this paper doesn't state much about the regional differences between Sweden, and we know that there were differences, and for example the Stockholm region was very badly hit by this heat wave when it comes to mortality. When we decided the thresholds for the Swedish heat warning system, we were asked to do this by MSB and SMHI, the Swedish Met Office, because they were asked to introduce heat warnings. We used Greater Stockholm area to study the mortality, the temperature-mortality relation. And the goal was to identify circumstances that led to 10% and 20% higher mortality, respectively. And we then found that 3 days with a daily maximum temperature of 27 degrees or more led to 10% more deaths in Stockholm. So that was used to define the lowest threshold in the Swedish warning system. It's not called class 1 warning when it comes to high temperatures. SMHI felt that it would be difficult to define a situation which most people maybe would find pleasant as something that would create a class 1 warning. So they said that, well, let's use this lowest threshold to define something called a message about high temperatures. So it's only the next level, 20% increased mortality in Stockholm, which needed 3 days with 30 degrees. That is defined as a class 1 warning threshold in Sweden. From our side, we meant that, well, if 10% in the population, if mortality increases by 10% in the population, wouldn't that be worth to call a class 1 warning? But still, we got this decision on a message about high temperatures. This was done, the initial analysis to have this threshold was done in 2013. So a few years later, with more Swedish data, more cities and more years, we did a new study on the temperature-mortality relations in a lot of Swedish cities and combined the results from all cities and found that now 3 days with 27 degrees didn't give 10%, but almost. We ended up with 8% as the combined estimate for all these cities. And you can see here that 3 of the cities are from northern Sweden. So what about those cities? Well, for Sundsvall, Umeå and Luleå, with 3 days with a maximum temperature of 27 degrees, we had an increase in mortality of 32%. Not 10% as we assume with the warning system, and not 8% as the combined for all Swedish cities that were included in the study. So, of course, one could ask, should we also in Sweden have regional warning thresholds? Should we have a lower threshold in regions where we see higher effects on mortality, in regions where we have a bit colder climate than in the south, for example, of Sweden? It's a quite large difference in the estimates here, and it goes in the same direction as in many studies, but not all studies find these differences. Our colleagues in Finland, for example, they did a study on temperature-mortality relations within a lot of different hospital districts in Finland. I can't remember exactly how many districts they used. And here you see the hospital district specific temperature mortality curve. So the y-axis, relative risk, means, for example, if it says 1.2, it means that at 1.2 we have 20% higher mortality at that temperature. And if we look at the warm side, and I should say also that in this study they used the daily average, the daily mean temperature. In the Swedish studies, more modern studies, we use the daily maximum when we, for example, define the thresholds. So it looks maybe a bit different than that. In Finland, they combined have 16% higher mortality at the temperature of 24 degrees, but that's the daily mean, not the daily maximum temperature. But in this study, they also tried to find out if, for example, the range in temperature or the annual mean and other factors could explain the differences between these curves, but it seemed that the differences are mainly explained by chance. It was difficult to find factors that could explain the differences. If we look here on the hospital district's climate and the effect on the relationship between temperature and mortality based from a regression analysis, they describe the effect at two levels. I think it was the 25th climate percentile and the 75th. So you see 3.5 would be then a lower mean, lower average temperature than 5 degrees. So we could in a way say that here we compare northern parts of Finland with more warmer parts. And if you look at the right side, the effect of and here it's also, I should say, it's the relative temperature, so it's the temperature percentile for each district then. But here you could see that it seems like there's a slightly stronger increase in mortality in warmer climates than in the colder. You see the 5-degree annual mean temperature representing a bit higher effect on mortality than the colder climate. So, but it's the same also on the cold side, that the warmer climate gives a stronger increase in mortality at the cold side also. I've looked for studies that could tell us a bit about differences in effects of temperature or mortality in countries with different climate zones. And China, of course, is then one country where we have a lot of people and a lot of regional capitals and different climates. And this is a graph from a paper showing that high latitude in China gives a lower temperature threshold where mortality starts to increase, where the heat effect starts. So in the coldest part, in the northeast, daily mortality starts to increase when the daily mean temperature goes above 20 degrees or 20.5. But in the warmest parts of China, the daily mean has to go above 26.1 before daily mortality starts to increase with increasing temperatures. And this is, I think, a more typical picture, the Chinese one, than the Finnish results. Of course, it's not only mortality which is affected during heat waves. We also have effects on the healthcare system. We know that the number of emergency room visits and the number of hospital admissions increase during heat waves. But it's quite interesting if we compare air pollution and hot weather or heat waves with pollution episodes. We often see a larger relative increase in the number of patients. The percent increase in emergency room visits or in hospital admissions usually is larger. The increase is larger for the number of patients than for the number of deaths. But with heat waves, it's often the opposite, that we see a larger relative increase in mortality than the increase in hospital admissions. It's not at all unusual when you study evaluations of the effects of heat waves that mortality is more affected than hospital admissions. And there might be several explanations for this. One explanation could, of course, be that people at risk, they don't really understand that they should seek health care. Another problem which we saw was obvious in 2018 is that the healthcare sector, the hospitals are after a while already full. So there are no beds available. And it becomes probably harder and harder to be admitted to a hospital clinic, and also the emergency rooms could be full, which was, for example, the problem in Stockholm in 2018. So the results or the patterns when it comes to temperature hospitalization relations, it is a bit less clear than for mortality, probably because there are many factors affecting hospitalizations. For example, the number of beds available, but maybe also the healthcare system who's paying, how high is the cost for the individual and so on. This is from a European study. It was published already in 2009 when we compared the situation in several European cities. What happens with extreme hot weather with the number of hospitalizations for respiratory diseases, which this table shows, and we studied also cardiovascular admissions. And if you look at the results here, it's you see the threshold, which is defined as when we have a heat wave. Here we have the 90th percentile for the mean apparent temperature over 4 days. It's like 0 to 3. So it's not daily maximum temperature, it's mean temperature. And for Stockholm, the threshold here was almost 23 degrees. But for example, for Rome, you see 34.5. So different climate, the different temperature distribution gives a different threshold. But so these are relative thresholds. And as you understand, heat waves should rather be defined from relative temperatures than from absolute. But you see that there's no clear pattern here how many percent the number of hospitalizations increases. You can't say that they increase more in cold cities or more in warm cities. It seems rather random. Stockholm has a quite high increase with 2.7% increase in the number of admitted per 1 degree higher temperature above this threshold. Almost 3% increase per 1 degree increase in the temperature. But you have Rome has an even higher, but on the other hand, you see warm cities where like Valencia, where we didn't observe for all ages any increase in the number of admissions. So I would say that for hospitalizations, they are less studied, but it's also less clear what happens during heat waves with hospitalizations. Yeah, it is possible to prevent deaths during heat waves, we know. This has been shown in many countries, in the US, for example, after severe heat waves in the 1980s. They succeed much better today to avoid deaths during heat waves. And in Europe, we had a very bad heat wave hitting countries like England, Netherlands, France, Spain, Portugal, Italy in 2003. And after the heat wave in 2003, many of these countries, they introduced national action plans, prevention plans to protect against health impacts during heat waves. These plans could include things that should be undertaken within the healthcare sector or in other sectors. In the north of Europe, for example, in Sweden and Finland, we were not affected by the heat wave in 2003. So nothing particular happened with how we deal with the threats from heat waves. And in this study, we compared the temperature mortality relation before 2003 with the temperature mortality relation in the same cities after 2003, when many countries then had introduced preventive measures. And if you look at these two curves, the blue one describes the temperature-mortality relation after the heat wave, 2003 heat wave. You can see that for cities like Paris and Barcelona and Rome, they see much smaller increase in mortality after the 2003 heat wave during the period up to 2010 for most cities. But in Stockholm and in Helsinki, we don't see that pattern. Quite opposite, in fact. We see that it gets worse and worse. And this we have shown also in a study where we compare how much mortality increases among patients with different diagnoses in Stockholm and in Rome, that it gets the situation or the increase in risk becomes smaller and smaller with time in Rome, and it gets worse and worse in Stockholm with time. So it seems that you have to have a very deadly heat wave to get the actions needed to take better care of susceptible persons, for example, to get warning systems and things like that working. Well, the health impacts could be modified by several factors. We know this from a lot of studies. It's, of course, it's the susceptibility in the population. Do we have a large fraction of fragile elderly persons with cardiovascular diseases or lung diseases, or do we have a healthy population? We also know that exposure varies. If you have a recorded temperature or observed temperature at the meteorological station, you could have much warmer temperatures in the inner city. In parts where we have a lot of asphalt and concrete, we talk about this urban heat island effect. This urban effect could of course be avoided if we have more lungs in the cities, more green parks or ponds or surfaces that don't collect or aggregate the heat in the same way as asphalt and concrete do. We also know that the impacts could be modified by air pollution levels. And in the same way, as I said, that wildfire smoke could be seen sometimes as part of the heat wave, high air pollution levels could also be seen as part of the heat wave. It might be a misunderstanding to adjust and take away effects on mortality, for example, that we could blame on air pollution when air pollution levels are explained by the heat wave. And we know that during heat waves, we often get high levels of ground level ozone, and ozone also has an effect on daily mortality. So the air pollution situation could worsen heat wave effects. And we, in a couple of studies from Southern Europe, we have seen that in areas where they have suffered from high levels of vehicle exhaust, the effect on mortality related to heat is also higher. So it seems that there is an effect modification also by vehicle exhaust on mortality. Then, of course, the standards or the way we take care of our elderly, housing factors and also healthcare factors could modify the impacts. In Italy, after 2003, they introduced a system where family physicians were especially paid if they, during a heat wave, contacted heat susceptible persons. It could be people that had recently gone through surgery, for example, or suffered from COPD or diseases which makes you more vulnerable for heat. And so the physicians were especially paid when they contacted these kind of vulnerable persons and for example, modified their medication or gave instructions how to behave during the heat wave. So we're getting to the end of my presentation. What should we do in countries or regions where we usually appreciate warm days. We long for the sunny days when we can go swimming. But when we see that we have increases in mortality, like the ones I mentioned for the 3 studies from northern Sweden, up to around 30% during a situation which is not that unusual. Okay, I think I leave the floor open now for discussions. How important is this and what should we do about it?